was realized at the end of the study as to, I wish we had just focused on one question. I wish we had tailored our study design to that question. And if that was done, that realization is down the line after 2 years, which is not of any use to our residents when they're doing their MD training or their DM training. We are one of the finest minds in the country, and we are not able to translate it because of these gaps in knowledge. So I hope this lecture will fill in those gaps in knowledge. So what is research? Research is in the whole population N, that is characterized by the big N, we will draw a small, representative, adequate sample to study, observe, and analyze. So this is what we are doing in a study. If you want to study all the diabetics in the world, you can never do that, because maybe somebody is diabetic who is just detected today, or somebody will be getting detected tomorrow. You do not know who is diabetic, all the diabetics. So even if I plan that all through the world, on one particular day I get the blood sugar of everybody, it is just not practically possible. So even theoretically it is not possible. So we have to always draw a small sample, which we have to closely observe and analyze, because we have to extrapolate this information to the whole population. So suppose you discover that a particular drug works well in CRF. You have done it on 100 patients, but you want to everybody to use this knowledge for their patients. So you want to, derive some knowledge from the small n and translate it into the big N. This translation is for what we need: statistics. So for this particular statistics, we need descriptive statistics, that mean, median, mode, what is the standard deviation, what are the numbers, what is the proportion, and all those kind of things, chi-square and all that. But when we want to go from here to the whole population, we need what we call as a confidence interval. Means, with what confidence can you say that what you have found in your group is what will be there for the larger group? So that determines a confidence interval, which in turn depends upon how big your small n is. If you have a very large sample size, say 10,000 patients, 20,000 patients, depending on the research question, your study will be stronger, your confidence interval will be narrower. So with greater confidence, you can extrapolate your limited data to all the whole population. If you do a study on 20 patients, it has its own inherent problems and biases, which will be difficult to translate into the larger population. So that is why sample, how you get it is important, and how you observe and analyze is important, and it should be adequate to allow you to extrapolate to the larger population. There's one more caveat in this. All statistical methods depend on the concept that you have randomly drawn the small n from the big N. However, we never do that, because suppose you want to study MPGN, you will not get so many MPGN in a particular year that your thesis can be done. So what you will do is you will take consecutive patients. So that is why when we say that from January 1st, 2010 to say December 31st, 2012, we recruited all consecutive samples. So it is important that if you can't do it random, minimum pick up all the patients with that problem which comes in, so that you minimum have consecutive patients of MPGN recruited in your study. This is the least which has to be done. So this is very important for the residents to realize that once you start the study, any patient with MPGN walking into the hospital should be in your radar. If he's included, he comes into your study. If he's excluded, he also is in your study, but you write why you excluded him. So this is very important. And if you see large number of studies which come from the Western thing, they'll say we screened 5,000 people and 20 people had this, or 800 people had this. So they have the denominator which is larger. So in order to keep a large denominator, it is important that you ensure that you keep a record of all the MPGN who have come into the hospital, whom you have included, whom you have excluded, and why you have excluded. So this information is very essential. This should be your first page of any case report form. Next. So what is research? We discussed drawing a small n from the big N, analyzing it and extrapolating it to the bigger population effectively. Then there are steps in this research. Unfortunately, these steps are never highlighted. We'll go through those things. How do we choose a research question? What is a research hypothesis? And what is the structure of the research question? So these are the points we'll discuss today. Research is science which is searching for truth. So you in your lifetime are going to add one drop of truth to the whole truth. And that drop should not be contaminated. That drop should be as pure as possible. So our research is going to be a drop in the ocean of research which has been done for years together and which will be done later on also. So we have to keep it pure, for which we need to understand appropriate research methods. Now, since there are no housekeeping rules here, so I will skip this slide. Now, what is the aim of research? Is to identify a particular disease, understand what is the frequency of the disease, realize what are the risk factors which cause the disease, or help in management. So any of these things can form a part of your research question. What are the risk factors for MPGN? What are the features which identify MPGN compared to minimal change? What is the frequency of MPGN among patients who come with proteinuria to the nephro OPD? Which drug used in management is better? So these kind of a thing can help us with formulating our questions. No, so there are steps in a process of deciding how to understand a research question. First, you have a problem in your mind. Suppose I say, okay, papaya can be used in dengue for treatment of low platelet level. So somebody comes and says, no, papaya is very good. So you as a researcher in India would like to, popularize your own ancient medicine. So you decide, okay, let me plan out a research question in the process. So your research question is, does eating papaya improve platelet count in patients with dengue? But this question has to be further refined. So we will decide how to refine it. So your hypothesis is that eating papaya improves platelet count. Let us say kiwi, eating kiwi improves platelet count. Then you have to decide how much sample you have to draw. Should it be 40 patients, 50 patients, 100 patients, 90 patients, whatever it is. What is the ethical approval you have to take from your ethical committee? You have to write a protocol. You have to register for the trial. You have to conduct a trial. You have to analyze a trial, and you have to report the trial and then disseminate the information. So what have you done? You have just had a problem in your mind, that is thrombocytopenia in patients with dengue. You have to convert it into a research question, which we will discuss right now. You want to then formulate a hypothesis, find out how much sample you need, get an ethical approval, write a protocol, register the trial. It is very important to register any trial, especially if it is a drug trial or a randomized control trial. You have to register it in CTRI, otherwise the papers will not accept that for publication, because unless registered, trials will not be published as a randomized control trial, because you have not a priori stated what are you going to study in that thing. So most people end up starting their study here. They start with some problem and they jump to conducting a study, then analyze, and then they report, but they are not able to get it into a good journal and disseminate that information, because later on people keep saying this was wrong and this was right. Am I audible to everybody? Am I audible?
Yes, madam, you are audible. You're audible.
Sorry, I just wanted to be sure, because here you don't get any visual cues.
No, you are audible.
Okay, thank you, sir. So research is answering a question. That is what is research. Answering it truthfully, for which you need to minimize your biases, and you have to understand research methodology. So where do these questions come? This gentleman, this doctor, is seeing this small boy with suspected pulmonary tuberculosis, and now he sees that the mother is also malnourished, the child is also malnourished. He feels that the outcome of anti-tubercular drugs in this group of patients is not as good as a person who's well built or comes from an upper socioeconomic status. So he thinks that if I give a nutritional intervention along with anti-tubercular drugs, maybe these children will do better. So this is a research question which he generated when he was sitting in the outpatient department. Now, when you're reading something, you're reading some particular article, suddenly that something clicks and you understand that you can use that particular drug in your own situation. So that is when another research question can come from. Third is you are trying to put a big puzzle together. Like I work on gallbladder cancer, so I've been constantly thinking, what are the factors which are causing gallbladder cancer in India? Sometimes you realize it's gallstones, sometimes you realize it's Salmonella typhi, sometimes you realize it's H. pylori, sometimes you realize that the gallbladder function is poor, sometimes you realize that there is gallbladder is not functioning at all. There is a lot of mechanical irritation of the gallbladder, or there is genetics which are working against the patient, or a family history which is positive. So all these things go into making a disease. So we are trying to put a puzzle together. So that is the third time when you get a research question in your mind. And fourthly, you're sitting in a conference, you're hearing somebody speak on a related topic, but not particularly your topic, and suddenly something clicks. We say, oh wow, I can use that in my condition. Oh, somebody says zinc deficiency causes immunodeficiency, causes leaky gut barrier. Maybe I can set the gut all right and improve something else in a patient. So all these things click in your mind when you're engrossed in reading or putting a puzzle together or seeing a patient or listening to a lecture. So how do you choose a research question? So many new questions come in your mind, but obviously we can't, try and answer all of them. So it depends upon your interest. It depends upon your institution's interest. It depends upon availability of funding. It depends upon what will interest the scientific community so that it will take science further. For this, we have a small acronym called FINER. I'll come to what is FINER. FINER is the study has to be feasible. That means it has to have adequate number of subjects. It has to have adequate technical expertise. So if you're working on a rare disease, you can't recruit those many patients, then how will your resident do the study? You have to have adequate technical expertise in your own institution to conduct all the components. It should be affordable in terms of time and money. It should be manageable in scope in terms of what you can do given your time constraints while working. I means it should be interesting. That means it should get you answers which intrigues the investigator, the peers, and the community. We have to also remember research is done because there's a passion to find that answer. Getting a publication out of it, getting a promotion out of it, all that comes alongside. But what drives research is your passion to find an answer to a question. Novel, it should be either something confirming some already existing doctrine, it should refute an existing doctrine, or it should extend a previous finding. So whatever is your hypothesis, it should confirm it. It's no point just having something just out of the blue. It should be ethical. So obviously our ethical committee should not find a problem with it, and we in our own hearts should know that if I enroll my own parent or my brother or my sister or my relative, I shouldn't find anything grossly unethical in what I'm doing. So if it crosses that touchstone, then you know that it has to be ethical. So we have to ask our own conscience and also have the ethical board approve it. The last part is it should be relevant. So it should be useful to our scientific knowledge of our population. It should be helping us change our clinical or health policy. It should help to future further research. So in some way it should be of some use to our community, because patients are going to give their time, they are going to be put at some risk, some inconvenience, some blood sampling, some testing, lab is going to work, money is going to get spent, some personnel are going to spend their time and money, you're going to spend your time and money, and all this money collectively comes from time and money comes from the society. So it has to flow back to the society. It should be feasible. So let us take these 4 questions, and since this is not an interactive thing, I will just try and make it as interesting as possible. So feasible, out of these 4, think in your mind which of these study questions are feasible, and then I'll give you the answers. Does exposure to sunlight increase vitamin D? Do you think it is feasible? Do you think that exposure to volcanic fumes increases risk of cancer? Do you think it's feasible to do such a study? Do you think it is feasible to say that living in Vedic style will improve longevity? Can we do it today? Does exposure to indoor pollution increase risk for lung disease? Can we do this study question today? So let us see, in your own minds you would have thought, and you see the first one and the last one are feasible, which are highlighted in blue. The second and the third are not feasible in today's day. So we will, if you have a question, always see whether it fits into these 5 criteria finer. Then, is it interesting? Is it whether a new drug can prevent diabetes? Is this question, does it interest you? Yes, it does interest you. With increasing diabetes in the country, it does interest us. Whether a new test can detect swine flu? Yes, it interests us. Now I can say new test can detect coronavirus. Whether a new agent can kill mosquitoes? Yes, it is interesting because dengue is a big problem in our country. Malaria is a big problem in our country. Whether smoking causes lung cancer, does that interest you? I don't think so, because we know that smoking causes lung cancer. What more are we going to do with it unless you say e-cigarettes, do they cause lung cancer? So the top 3 are interesting questions and the last one is obviously not interesting. Next we come to novel. Again the same things, that is it a new thing that a new drug can prevent diabetes? Yes, it's a new idea. A new test can detect swine flu? Yes, it's a new idea. It's worthwhile pursuing. Whether a new agent can kill mosquitoes? Yes, it's a novel idea. Novel need not be only new. It may be a different way of thinking about the same problem. So it is necessarily not a new drug or a new test or a new agent. It can be completely a new way of looking at it. Like recently we started looking at gallbladder function, and we found that the people with poor gallbladder function more often have preneoplastic lesions. So that among patients with gallstones, we can pick up these groups which have poor gallbladder function and subject them to prophylactic cholecystectomy to prevent gallbladder cancer. So it's a new way of looking at an old problem. So new does not mean just a drug or a test or an agent. It can be a new way of looking at an old problem. Is it ethical? So whenever you have to do a study, there has to be a state of equipoise. That means we do not know what is right and wrong. So out of these 4 or 5 things, can you tell me which ones are ethical? Think in your own mind. Whether exposure to nuclear radiation increases risk for cancer. A randomized controlled trial, can we do something like that? No, we can't do. We can't expose somebody to nuclear radiation and put them at risk for cancer. Whether exposure to a low calorie diet will increase the risk of fetal anomalies. Can we do that? No, we cannot jeopardize the fetus in the process. And instead you can turn it around and say whether adding a nutritional supplement decreases the risk of fetal anomaly. So the same question can be turned around and made more ethical. Drug A versus placebo, when doing an RCT, when drug B is a standard of care, can you give one person cyclophosphamide for nephrotic syndrome and give nothing to the other group? You cannot. You have to compare it with some arm, maybe steroids or something which is already the standard of care. Minors versus non-minors risk of lung disease. We know that they are at risk of lung disease. We can do, add a mask for them to reduce their risk of lung disease. So that can be an intervention, and you can do a randomized controlled trial. So obviously all these are, first 4 things are not ethical. In the last one, you can add a mask to minors to make it more ethical to reduce the risk of lung disease. So ethical basically revolves around one concept, that whatever you do should be with the intention to improve the intervention group compared to the standard of care. So whatever additional thing you're doing should be to improve that particular set of people. Is it relevant now? As I said, whether exposure to nuclear radiation increases risk of cancer, we know that. We know that from the Hiroshima episode that it increases. We don't need to show that even more. Whether exposure to high protein diet decreases risk for fetal malformation, yes, this is relevant in our country where we can improve the nutrition of our pregnant women. Using special masks for minors reduces risk, yes, this is relevant. So next step is writing the research question. So we have chosen a research question which is feasible, interesting, novel, ethical, and relevant. After you choose that, now you have to write it. So you write it in detail, you read literature, you do a good literature search before you write your question. Why? Because somebody may have done some work on that before, there's no point replicating. Somebody may have done it in a different way. You can learn from whatever they have done, look at all that data in a detailed way. In fact, when I was working in Canada, I realized that whenever a student has to write a research protocol, he ends up publishing a systematic review before he even starts his own study. Why? Because he has combed the literature, found out what it is in a systematic way, and then he knows all the existing data, and then he picks up something which has not been done in the past. Then he refines that question, adds focus to it, adds an objectivity to it, and adds structure to it, and that is how he writes his research question. Now let us see this situation. That is the third concept of this lecture, that is PICOTS. So the first concept was finer. Second concept was how to write it in a structured way. And third concept is PICOTS. So PICOTS is, you have to define what population is being studied, what intervention you're going to do in that study group, what is the intervention in the control group, what is the outcome of interest, what is the time frame in which the outcome is going to be measured. So you do an intervention today, are you going to measure the outcome in 3 months, 6 months, 1 year? Are you going to measure the outcome in 1 day? Say suppose there is an anesthetist who has now a new type of ET tube, and he has the standard ET tube. So he's going to use the new type of ET tube and see whether patients who had the new type of ET tube, did they do better in the immediate post-op period? Did they have less throat irritation? Did they do well in the next 5 days after extubation compared to the other group? So your time frame of the study is just as small as 5 days. So a time frame does not mean it has to be running in years. It is for that index patient from the time when the patient comes into the study till the time the patient is being observed is the time frame of the study. So your study can be for 5 years, but if you are observing a patient only for 3 months, your time frame of the study is 3 months. Then the study design, whether you choose a randomized controlled design, you choose a cohort study, you choose a case control or a cross-sectional study. But my general advice to anybody would be, if you can do it as a randomized controlled trial, please do it as a randomized controlled trial. If it is not feasible or ethical to do a randomized controlled trial, please do a cohort study. The third important caveat of study design is any study should have controls. Without controls, study design is useless. So you can't do a study without having controls. The fifth thing is controls are as important as cases. So start recruiting your controls at the same time when you're recruiting your cases. So these are important caveats when you decide your study design. So coming back to PICOTS, it's again an acronym for P, which stands for patient. It can stand for population, it can stand for problem. So it can be patients with diabetes, it can be a population living in Bathinda, it can be a set of patients with a dengue as a problem. So it can be any particular set of, the P can stand for any of the 3 P's here. The intervention is very important for all of us to understand. It may be in the form of a drug. It may be exposure to mining. It may be exposure to radiation. It may be exposure to a drug. It may be exposure to toxin while attending a marriage function, food poisoning toxin. It could be a diagnostic test, as we discussed last time. It is just one group gets a particular diagnostic test, one group gets the other diagnostic test. So one group gets the, both of them will have to have the reference test as we discussed last time, but one group gets the diagnostic test. It could be a prognostic factor. You may be doing a fibroscan of the liver to assess what is the degree of fibrosis and predicting the outcome of that particular patient. You may be giving treatment of a particular kind to one group compared to the other group. It may be a behavioral intervention. It may be asking people to wear a mask and show that mask reduces corona transmission. So it could be anything. It could be a comparison with the placebo or the standard of care or non-exposure. So you have to have something which will work across this, so that whatever is happening here is also going to happen here minus that particular intervention. Everything else remains the same for the comparison group. The outcome includes the clinical outcome of interest and the diagnosis. So it may be whatever, reducing mortality, morbidity, reducing pain, reducing proteinuria, reducing dialysis requirement. It may be whatever you may want to choose as your outcome. And it may be, if it is a diagnostic test, it can end up in as a diagnostic test could be your outcome. The effect size of the outcome is the difference you are trying to see between the intervention arm and the comparison arm. That means in the intervention arm, if you have 80% showing response and in the comparison you are having 20% showing response, the effect size is 20%. So if you are preventing disease in 70% patients and corona transmission in 70% versus 20% without mask, your effect size is 70 minus 20, that is 50. Okay. These are effect size is very important when you're planning your sample size. So choosing the appropriate outcome is very important. Quite often many people make a mistake here, because you have to choose an outcome which will be captured during your period of the study. So it should be something objective. It should not be just a surrogate outcome. It should be relevant to the patient. Many journals keep on asking that your outcome should be patient-related outcome. When Cochrane does its study analysis, it always looks for patient-related outcomes. So what are patient-related outcomes? What matters to the patient? To you, a low LDH may be important, but to the patient, he wants to survive. He wants to go out to the hospital faster. He wants to improve faster. And he wants to not have any lasting morbidity. So these are things which are relevant to the patient. Patient may want to spend less money. Patient may want to have improved quality of life. So all these are patient-related relevant outcomes. So you have to decide what you are interested in, and you have to beware of surrogate outcomes, which I said LDH may improve, but the patient doesn't improve. pH may improve, but the patient doesn't improve. So those things are just telling us something pathophysiologically is happening, but it is not translating into something which is relevant for the patient. So let us see what are these surrogate outcomes. Albumin and crystalloids for hypotension. A lot of debate keeps on going on. Should we give albumin? Should we give saline to these patients? You can say, okay, the lactate level improves with crystalloids, pH improves, but does not impact on death. So what is the use? So there's no point, improving some lab parameters, but not improving the patient. Drug A versus drug B for fatty liver, we say, okay, the lipid profile improves, the liver fat decreases, but it doesn't reduce cirrhosis or death. So what? So it doesn't make any sense. So it doesn't matter to the patient. So it's of no use. So it is usually surrogate outcomes are useful in pathophysiological pathway understanding. So you can do it along the side, but don't keep it as your primary outcome. Like when I do studies on ulcerative colitis, I use improvement in the clinical scoring of the patient as my primary outcome. My secondary outcome is reduction in fecal calprotectin, so that it is a very good surrogate to tell us about disease activity, but that cannot be my primary outcome. So now let us see another concept, what is called clinically significant difference. Now tell me, as a clinician, you all must be treating more hypertension than I ever do. Drug A, a new MR comes to you and says drug A is reducing blood pressure by 1 millimeter more than the placebo. Will you prescribe it? No. Drug A reduces blood pressure by 4 millimeter more than the placebo. Will you prescribe it? No. Drug A reduces by 10 millimeter. You may start considering prescribing, because with every new drug, you have to change the prescription, you have to tell the patient, you don't know what side effects that thing will have, what drug interactions will be there. And as I feel, I always know 100 or 200 drugs well. Adding one more drug to the armamentarium of which you are not confident about creates a problem for a clinician who's treating patients with multiple drugs. So a drug which reduces blood pressure by 20 millimeter, obviously I'll be interested, but I'll be careful that, it suddenly doesn't plummet the blood pressure. So in this situation, the third option is something which is interesting for me to pursue, because clinically it is relevant to reduce the blood pressure. Though WHO may say that reducing even 1 millimeter of mercury of blood pressure is better, but I will not embark on a study in which I am able to show only a reduction of 1 millimeter blood pressure. So if you go and present such a data in a nephrology conference, nobody is going to start prescribing the drug that you're advocating. So it's of no use. So 1 and 4 is of no use. So what is it? You're trying to weigh the risk versus benefit. What is the risk of prescribing a new drug? You have to familiarize yourself with it. You have to tell the patient it has to be available in the local market. It may be more expensive, and it may have unknown side effects. And the benefit, if it's only 1 millimeter, why should I prescribe? I might just carry on with whatever I'm carrying on. So always your benefit should outweigh the risk when you're prescribing a new drug. So, and this is the basic principle of evidence-based medicine. So then we discussed about what was effect size, how much difference is expected in the outcome of interest. What is the direction of difference? Do you say that your intervention group is going to be superior to the other group? Is it going to be non-inferior to the other group, or is it going to be equivalent to the other group? So that is the direction of the difference. So how much difference we discussed? Mask reduces corona by 50%. That is the difference. That is the effect size. And in the other example, we said 80% versus 40%. So 40% becomes our effect size. So, but the most important thing is this effect size has to be decided a priori. Means before you start your study, you should in your mind think, if I present this study to everybody, how much will they be interested in changing their practice given the fact that this drug works? If I say that this drug works, if it reduces blood pressure by 10 mm, people will be interested. So a priori, I decided only if it is 10 mm, I will consider the study to be successful. If it is 2 mm, 4 mm, I will not consider the study to be successful. So effect size, how much it is, and you have to decide beforehand as a clinician. It can be just a good clinical judgment of what will make you change your practice. It has also a role in your sample size calculation. Smaller the difference you want to pick up, you need a larger sample size. Larger the difference you want to pick up, you need a smaller sample size. So more effective the drug, you will need a smaller sample size. Less effective a drug, you will need a larger sample size. Suppose you are doing a study between crocin and dolo. Both of them are paracetamol, slightly different in formulation. You will need a large sample size to say that, okay, fever reduction is more in dolo group compared to the crocin group. So it is an estimate of what you think is important. Now, what is a research hypothesis? It is the same thing which contains all these components. It has a statement, it has the PICOTS, it has the effect size, it has the direction, and it is detailed. Now, I'll just show you in your next slide. This is how, if I was planning a study on hypertension, I want to write my hypothesis. Now, let us read this carefully, and I have color coded it for us to tell us all the 4 components. In adult patients aged 20 to 60 years, that means I'm defining which patient I'm seeing. So this is my P. With established hypertension, it is not just one day white coat hypertension, defined as blood pressure more than 140/90 millimeter mercury, attending outpatient department of PGI. So I've defined from where the patient will come, who the patient is it, what is he having, so that anybody can recruit a patient amongst this. Giving losartan 25 milligram taken once a day in empty stomach, compared to atenolol 100 milligram once a day in empty stomach. Is it likely to additionally reduce the mean systolic blood pressure by 10 millimeter after 1 month of regular treatment? You see, in this hypothesis, everything is coming. It tells us the P, it tells us the intervention I, it tells us a comparator, that is C, it tells us what is the outcome we are looking at is reduction in mean systolic pressure by 10 millimeter, and this tells us the effect size, that is 10 millimeter, and this tells us the time frame, that is 1 month after regular treatment. So all our components have come, and if I add to this by a randomized control design, the S will also come. So a hypothesis is not just a one sentence thing, it is a detailed understanding of what you are looking for. So the objectives are an active statement of the hypothesis with the key elements. It will be primary and secondary objectives. It contains study design. Example, we did a study to determine the role of oral vitamin D nano formulation in reducing disease activity among patients with IBD compared to oral vitamin D. So this is the title of the study, which contains the intervention. It contains the comparison. It tells you what patients it is, and it reduces, and with what outcome is to reduce disease activity. So this is how we write a objective of a study. So to summarize, it is very important to focus on the research question, apply the finer criteria, and then you write in detail, do a detailed research, literature search, and see that you are not replicating what others have already done. Look for new things and read other people's discussions, which will tell you what is the undone thing which you can start doing, and write it over and over again, 10 times, 15 times, 20 times, till you get to formulating what you have in your mind on paper. Show it to others. If other people suddenly may give you different inputs, may tell you whether it's interesting or not, whether it's novel or not. Otherwise somebody may say, अरे इसमें करने का क्या फायदा है? अरे वाह, ये कर रहे हो, बहुत अच्छी बात है, मुझे बताना जब रिजल्ट आएगी क्या आया इसमें. So when it interests other people, that means it is novel. It is something which is interesting other people, and it's new. It should be objective. There is no point saying it will in general reduce morbidity or mortality, but it should be objective, that it reduces death rate by this %, it reduces, it improves quality of life by 20 points, it reduces blood pressure by 10 millimeter of mercury. So there should be an objective, measurable, conclusive outcome. And it should be particularly sufficiently specific so that somebody else in Norway can repeat that experiment. So how we used to write our chemical experiments in our 8th standard book. We had to write every component to it. So similarly, when we write our methods, it should be so detailed so that anybody can repeat the experiment completely. So I leave you with this question, this quote, which says, it's preferable to have an approximate answer to an exact question than to have an exact answer to an approximate question. So in your own minds, you can take time and you can write out these 4 or 5 things as a personal exercise. Does eating egg increase cholesterol? If you want to plan a study, how will you write its research question? How will you write its hypothesis? Does exposure to sunlight increase vitamin D levels? Does CSF ADA as a diagnostic test for tuberculosis, how good is it? Does increasing salt increase the blood pressure? Do men drive better than women? So there can be various kinds of questions. So this is just the problem I have stated. This has to then become a research question, a hypothesis, then a study design and a plan, and execute, and then report, analyze and report it. So let us just take this one question. Does exposure to sunlight increase vitamin D level? This is a question I've done with a lot of groups before. And here you see, I have put it in PICOTS. Among healthy adults aged 20 to 60, exposure of 30% of skin surface to direct sunlight between 11 a.m. and 3 p.m. in summer months. So my intervention is very specifically highlighted. Every component is done. And compared to those who were not, does it increase serum vitamin D level? We can serum vitamin D level after 1 month of daily exposure. That comes a time frame. by more than 5 nanograms per ml, that is the effect size. So you see the same question has been now put into an objective format. We have to remember that the diet the patient is taking can confound. Patient may be taking eggs and you have kept him in the placebo group, his thing will go up. Here you will have skin color will and so you can anyway not do something at a population level. Population is that big N. You're taking a small sample, the small n, dividing them into two groups randomly and then assessing them. So there's obviously no population in this. We are drawing our patients from the population as a sample.
Then there's another question from Dr. Anita. Is it acceptable to have a cohort example like hypertension and renal failure progressing to dialysis and a long-term follow-up without control? So she is asking whether we can publish such sort of data. What she wants to do is she wants to have probably a long-term follow-up of hypertensive patients with renal failure progressing to dialysis.
Okay, so what she can do, of course, this is like a cohort design. So one group is having hypertension and she is following them up over a period of time to see whether they are dialysis requiring or not requiring. So say she starts with 100 patients who are having hypertension and some renal dysfunction. She follows them up over a period of 5 years or 10 years to see how many of them go on to require dialysis. So this is like a Kaplan-Meier curve which she will have, that some people will go down and require dialysis, some people may not require dialysis. So what she has to do is she has to meticulously look at the hypertension at every point of time that she's seeing the patient, maybe 3 monthly, 6 monthly, whatever, and ensure that they are all taking the hypertensive medication. And thirdly, she has to follow up their renal functions over a period of time, define what she will consider as renal failure requiring dialysis, because nephrologists also will be dialyzing at different level points. So she should define what she will say as dialysis requiring. And then at the end of 5 years, pick out of those 100 patients who are the ones who received dialysis, who are the ones who did not require dialysis, what were the characteristics of people who receive dialysis. So that maybe poor hypertension control, poor compliance, obesity, some other diseases, too many drugs, NSAIDs, maybe that has shifted a patient to requiring more dialysis than the other group which did not receive dialysis. Is definitely publishable, and definitely in our own country you can find out what are the factors which is pushing people towards dialysis.
Then again, there are two questions from Dr. Manjunath and Dr. Mayuri Trivedi. Again, it's regarding RCT. So I hope we can actually take it up later.
One is a control. So for each case, you can match and take a control that, okay, this is 50-year-old man, 50-year-old man. Here also I take 2 years as my control. Or I can take just cases, I can take just controls without matching for age and adjust it at the time of analysis. So in these two groups, now I ask them with a questionnaire: how often do you smoke? How many years you have smoked? What do you use, cigarette or BD? Do you eat tobacco? Do you chew tobacco? So I'm asking all those things. And in the other group also, I'm asking all that. So now putting it into a PICOTS format. So out of patients presenting to the chest OPD, how many people have, among people presenting to chest OPD with a chest X-ray or a CT evidence of lung cancer, compared to those without CT evidence of lung cancer, what is the proportion of people having smoking index of more than 20 or more than 40 or whatever? So that becomes my yes.
There's a request to other participants. Can you please unmute yourself? There's quite a lot of interference. So there is another question. Comparing two diagnostic methods in a population, do we still have to meet all the components of the PICOT format?
We have to meet all the components of
the PICOT format.
Of course, Yes, for diagnostic test also I told you that is a form of intervention. So one group, suppose it gets RT-PCR for corona, another group is say getting just the COVID antibody. One group is say the reference standard is say RT-PCR. So that is your reference test, and the exposure group is getting a new test, maybe a salivary test for COVID. And RT-PCR will be done in both the groups, and the COVID test will be done additionally in the intervention group, and the outcome is the correct detection of COVID. So what percentage of people with COVID antibodies are correctly being detected by the PCR test, so that becomes your outcome, and later on you can calculate your sensitivity, specificity and likelihood ratios.
And there's one more question. We are actually have to start the session by 3 o'clock. So perhaps this is going to be the last question. How to accommodate in research question if the study outcome is a result of the disease per se versus outcome of the disease? For example, uric acid causing CKD versus CKD causing rise in uric acid. How to decide which one is the cause and which one is the effect?
Yeah, cause and effect is a completely separate thing altogether. One is, there is what we call as the Bradford Hill criteria to first tell us, is it biologically plausible that CKD is causing uric acid elevation or uric acid elevation is causing CKD? So you have to understand the biology behind it. Second is temporality. That means, was the patient having hyperuricemia and then went into CKD, or the patient was CKD, had normal uric acid and then that kept on rising? We know as clinician both of them are true. So we know, so that is temporality. And the amount, the amount of rise means what is the specificity of this association, the strength of the association. Strength is, if all CKDs will have elevated uric acid, then it tells us that most probably CKD is associated with elevated uric acid levels. If all hyperuricemic people land up in CKD, you know that hyperuricemia is landing up in CKD. So then specificity. Is it very specific that, okay, in CKD so many parameters rise, along with that uric acid is also rising? Or is it that only in CKD, only this particular parameter is rising? Is it very specific for CKD? So if you read the Bradford Hill criteria, you will understand whether it is a chicken or the egg. So most important thing here is the temporality. What came first? Yeah.
Madam, this is, I think actually there are more questions, but probably we'll stop with this one question. Somebody is having confusion regarding primary endpoint and secondary endpoint. So how to decide on primary and secondary endpoints?
Primary endpoint should be what must be most relevant to the patient, what you can easily achieve in your study design, what if you show will make a change in clinical practice. So primary endpoint is something which is chosen based on these kind of criteria. Suppose I'm doing ulcerative colitis, I want to reduce disease activity. So that is the most important for me as a clinician, most important for the patient. So I will say 3-point reduction in the Mayo score is my primary endpoint. However, as I said, a surrogate endpoint like calprotectin can be a secondary endpoint. The reduction in calprotectin by 50 units, 100 units can be my secondary endpoint, or reduction in CRP by 10 units can be my secondary endpoint. But my primary endpoint is always patient oriented and what is feasible in that time frame that you're studying.
Madam, there are a few questions, but basically they are all sort of personalized questions regarding individual studies and all. So madam, can you go through these questions later and try to answer them over email?
Can you just send these questions by email to me? I will then answer them.
Yeah. So with that, actually we finish this session, and thank you madam once again for an excellent presentation.
Thank you so much.